This is something big for us. We are venturing out of our dental mindset and expanding with Dr. Joe Scharpf. So let's talk about xerostomia. I've been in practice now 30 years outside the University of Chicago, and my patients all got old. And as they got old, they all got dry mouth, or it's really become a huge issue. I watched my dad suffer with this. I've seen many of my oral cancer patients referred from the University of Chicago suffer through this. And I think this is so apropos considering 30% of all adults, I believe over 70, suffer some form of xerostomia. So with that, let's go to the expert, Dr. Joe Scharpf. So he's not your everyday doctor. He is the professor of otolaryngology, head and neck surgery in the Cleveland Clinic, which I love, at the Lerner College of Medicine, and a member of the Cleveland Clinic's Head and Neck Institute in, of course, the head and neck surgery section. He is board certified in otology. He's a head and neck surgery. His specialty interests include thyroid and parathyroid surgery. So make sure you're wearing your aprons, everybody. Head and neck cancer, benign head and neck tumors, including salivary tumors, and a word I don't even know how to pronounce, and skull and base surgery. He serves as the director of head and neck endocrine surgery at the Cleveland Clinic. Now, I could continue to read this, but then we would only have about a minute and a half for his intellectualism in his subject of xerostomia. So with that being said, Joe, Dr. Scharpf, I would love you to take over and really enlighten us to what we're dealing with. Thanks for being here.
Thank you. Thank you very much, Dr. Graham and Lisa, for inviting me. It's a great honor to be here to speak on xerostomia. I'm actually also venturing out of my comfort zone of what I normally do. I focus a lot on head and neck cancer patients at the Cleveland Clinic. That's my main emphasis. And I've also seen, as Dr. Graham has seen, patients suffer terribly. I've seen patients suffer terribly from the effects of radiation. I've also seen patients who have not been radiated who, through aging process, medications, have suffered from xerostomia. And so this has created a very interesting avenue for exploration for me, in that xerostomia is something that is so prevalent in our society. It is such a negative factor in survivorship, which is a main focus in head and neck cancer. We're no longer in the days of just the patient survived cancer. You should be happy with that. We're more concerned now about how well they're surviving, how their life is going. And this is applicable not just to our cancer patients, but as you'll see, just about any patients that you're going to encounter in your practices. I do have a disclosure in that I am a strategic consultant for higher labs, and have been involved with development of a strategic implementation of products for them. As I present the overview here for the lecture, it's going to go over some basic definitions of xerostomia, touch on the etiology, evaluation, and then some management strategies. And it's aimed to be practical for our practitioners out there, whether they're dental hygienists, dentists, other physicians, family practice, anyone dealing with patient care. When we look at the definition of dry mouth, it's really very simply a complaint of oral dryness. It's defined as a subjective feeling of oral dryness, and it occurs in a huge proportion of the population, depending on which literature you'll look at, anywhere ranging from 5% to over 46%. It's most commonly in older patients above age 45 years of age. Most patients will not have objective signs of hyposalivation, and we'll touch upon what those objective signs are in terms of actual flow rates. But what is very clear is that it often leads to a very poor quality of life. Anywhere from mental health concerns, from mild anxiety to very, very severe depression that can be disabling for our patients. The prevalence of this is enormous. It's one of the fastest growing oral health problems in North America, and by extension, really the world. Increasingly common in developed countries for several reasons. One, We have a longer lifespan, and with that longer lifespan has been an increased use of medication. And medications represent one of the most common reasons for patients getting dry mouth or the side effects of medication causing xerostomia. So more than 80% of adults in the US take at least 1 or 2 medications, and 35% take at least 5. We also know that salivary tissue will decrease with age, but older, healthy, non-medicated individuals do not necessarily show a decrease in salivary function when you compare those to younger patients. As we look at this prevalence of dry mouth coming from studies, you can see here very clearly in the graph, I'm sorry about that, the prevalence does increase with age, which is on the x-axis, y-axis is your prevalence. It does affect both males and females, but does tend to affect females more commonly than males as we look at the studies. We look at our salivary composition, we often think of it as primarily water, and in fact it is primarily water, but there's far more than just water to our saliva. It contains cellular components, enzymes, electrolytes, many of the components that keep our mouths healthy. And so for many of my patients who have been through radiation, for example, and have lost their salivation and their saliva, they often have severe dental decay and teeth despite all their best efforts, because those components, those protective factors are simply not there, and they're suffering from horrific dental hygiene issues. And so the saliva has a role that is far more than just keeping our mouths moist. It's important in the preparation of food for swallowing. It modulates taste. So our initial digestion is by salivary amylase, maltase, very important elements for modulating taste. It does maintain an oral pH from 6.8 to 7.2. Moisturizing dilution, so it facilitates oral mucosal integrity. It protects actually even beyond the mouth, so it protects the upper alimentary tract as it buffers gastric reflux. And so within my field, I have many patients coming in at times very worried that they have cancer of the throat. Meanwhile, they have horrific reflux or laryngopharyngeal reflux, and saliva does play a role in buffering this gastric reflux. It also has an important antibacterial effect to reduce the risk of caries and periodontal disease. Irrigates the mouth of food debris, microbes. It does control pain and bleeding, which come from the dryness, promotes healing, and then it dilutes those sugars that we ingest in our foods. As we look at the production of saliva, we have the major salivary glands, and these are involved with intermittent secretions. And so that would include the bilateral parotid glands, the sublingual glands that you'll find in the floor of the mouth underneath the tongue. And then you have the submandibular glands underneath the jaw that have the Wharton's duct that opens in the floor of the mouth anteriorly, often finding stones at times in those areas if there's salivary stasis. You also have minor salivary glands where you have continuous secretions, and these are found throughout the lips, the cheeks, the palate, the tongue, the floor of mouth. All of this tissue is very much susceptible to the effects of local regional treatments such as radiation or systemic treatments with medications that would affect the salivary flow. When we look at salivary flow, these are some of those objective measures that I had mentioned previously. So the average person will produce about 3 pints a day, half a liter to 1.5 liters. And the salivary flow pattern is often an afternoon peak, and then you have a decrease at night when major salivary glands are less active. Many times we'll have patients coming in saying that they have too much saliva and mucus in their throat. Well, we're all producing a lot of saliva, and if we're not swallowing well, maybe those are the multifactorial issues of aging with swallowing deficiencies. The salivary flow gets interrupted in terms of being able to get rid of those saliva secretions, and a buildup of saliva in the mouth could be a problem as well, opposite of xerostomia. So as we look at xerostomia, these are the functional difficulties that will occur, and they include functional difficulties of swallowing, chewing, speaking, altered taste. When we look at the morphologic findings and the consequences, patients will complain of burning mouth, halitosis, dry buccal mucosa, glossitis, inflammation of the tongue, cracked and peeled lips, and then becomes an issue with infections, with oral candidiasis or fungal infections, and the dental caries that are such a prevalent issue for those within our dental community. These are the types of images that you will see when you see your patients, this profound dryness that is just very clearly seen with the cracking of the tongue and the dryness that's present. Some other images here, once again, showing that dryness, maybe even some early incipient candidal infection, and more profound dryness on the lower right screen. There are different surveys that can be given to patients, and these have been tested to try to objectively look at issues for patients and get surveys for them to see how much they're suffering from the dryness from xerostomia and how that's affecting their overall quality of life. And so these are basic questions that come up frequently in many surveys, but do you experience mouth dryness during the night or upon waking up? Do you experience mouth dryness during the day? Do you keep a glass of water next to your bed? Do you drink fluids while swallowing dry foods? Dryness during meals, problems with swallowing foods. Do you need chewing gum on a daily basis to eliminate a feeling of mouth dryness? Do you use hard fruit or mint candies to eliminate a feeling of mouth dryness? Do you perceive the volume of saliva in your mouth as too small or excessive? Or do you notice it changing? Do you need to moisten your mouth frequently? What will cause dry mouths? I've alluded to some of the issues, but we're going to go into this in a little bit more depth. Certainly systemic diseases can be an issue, and those systemic diseases I'll touch on one by one, but would include endocrine diseases, autoimmune diseases, infections, granulomatous disease, and other systemic causes. We've touched upon some of the local factors. Medications, number one on the list. Head and neck radiation, I've already mentioned. And then lifestyle factors such as smoking and alcohol, which we'll touch upon. When we look at systemic diseases such as endocrine disease, diabetes, a very common and prevalent situation in our society as we're fighting huge issues with diet, obesity, and diabetes that's come from these lifestyle choices, or not lifestyle choices, as some people are born with type 1 diabetes. But dry mouth is a common symptom of uncontrolled diabetes. And so seeing a dry mouth, I'm sure there have been many dentists in the audience or throughout our country who have actually diagnosed patients that were even unaware that they might have diabetes, just looking at their mouth and the dryness and the dehydration, and then hearing their history of polyuria. It's reported in 38% of children, 53% of adults with type 1 diabetes, and then 14 to 62% of patients with type 2 diabetes. Sjogren's syndrome hits the top of the list when we speak of autoimmune disease. There are Sjogren societies and support groups. I do get referrals from my rheumatology colleagues at my own institution when patients are complaining of xerostomia, dry eye, polyarthritis, and there are proteins against the glandular duct elements, and that's why I get the consults, because they'll often want me to do a lip biopsy and try and find some pathologic evidence that someone may be suffering from Sjogren's disease. Rheumatoid arthritis, systemic sclerosis, and also sarcoidosis can contribute to xerostomia. Infections are always an issue that can result in xerostomia, and one that we see within the mouth that could be particularly pernicious for many reasons is actinomycosis. And I wasn't quite as aware, but actinomycosis will infiltrate the parotid submandibular glands, cause abscess, as well as concerns for viral infections. So HIV, hepatitis C, cytomegalovirus, and Epstein-Barr virus all can contribute to xerostomia. Granulomatous disease. Tuberculosis not only infiltrates lung tissue that we're all familiar with, but can affect salivary tissue. And then once again, sarcoidosis, which tends to mimic many other diseases, is present and affecting patients with xerostomia. As we look at other systemic diseases that might not be as common depending on where you practice or the type of practice, chronic graft versus host disease. And so I do see many patients who have had transplantations, and they may have immune-mediated disease involving many organs that occurs after hematopoietic stem cell transplantation. The majority of patients, 53% of patients with this will experience the symptom. Hemochromatosis and amyloidosis are other systemic diseases that can contribute to xerostomia. So a very wide range of diseases affecting patients that will create this dryness within the mouth. Local factors, perhaps one of the most important ones is medications. Direct cause of more than 90% of xerostomia cases. There are more than 400 medications that are estimated to affect salivary function and lead to hyposalivation. These are some of the more common offenders, and you can see how common these medications are. Diuretics, of course, patients are using those for hypertension very commonly. Antidepressants, very common. Antihistamines, neuroleptics, bronchodilators, anxiolytics, cholinergic agents, hypotensive agents, opioids, immunostimulants, appetite suppressants, anti-migraine medications. Many chemotherapies not listed there will also contribute to xerostomia. One of the issues that I have already alluded to several times is head and neck radiation. And even with the most modern techniques with intensity modulated radiation therapy, this over and over again becomes a leading cause of dissatisfaction, or I should say complaint, from patients who feel very fortunate enough to be alive, but still it's a negative when it comes to their survivorship in terms of enjoying food and having that normal salivary function. And so there is destruction of the acinar system and stem cells of the salivary gland. It leads to atrophy, fibrosis. This is not reversible. This destruction and apoptosis occurs with exposure at 60 gray or higher. Most of our patients are getting 60 gray or higher standard. And if they're getting primary chemoradiation without surgery for a cancer, they're often getting close to 7,000 centigrade or more. We have a huge epidemic within this country of HPV oropharyngeal cancer. And so I expect that this will continue to occur more and more frequently. And as many people are aware, HPV oropharyngeal cancer is affecting many non-smokers, non-drinkers, young patients from essentially sexually transmitted cancer for HPV, human papillomavirus, and a lot of effort's been put out for vaccination for patients to try to prevent this in future generations. Local factors, smoking, alcohol use, including alcohol in mouthwashes. And so many patients really don't recognize this, many of my own patients, that so many mouthwashes can be full of alcohol, a leading factor that can create xerostomia and difficulties. Recreational drug use, including methamphetamines, and then caffeinated beverages. We're all drinking a little too much caffeine to keep going nowadays, and that will certainly have an effect. Many of the patients I've already alluded to can have heavy snoring in terms of issues with obstructive sleep apnea, weight issues, and when you're in that heavy snoring category, dehydration, mouth breathing becomes very common. Using CPAP, all of these with continued positive airway pressure, one of the main treatment modalities for obstructive sleep apnea, all will contribute to dryness within the mouth and a decrease in satisfaction in terms of overall quality of life. When we evaluate our patients, there's nothing probably as important as just beginning at the beginning, as we were taught in dental school, medical school, hygiene school, of a good comprehensive medical history, reviewing the patient's medications, asking patients if they've had a change in medications, reviewing their social history, particularly alcohol use and smoking. And then on the physical examination, we're looking at specific characteristics within the mouth. It is very accessible to examine, looking at that glassy oral mucosa, smooth gingiva, losing the papilla on the dorsal tongue, lobulated tongue, foamy saliva, minimal accumulation of saliva in the mouth, halitosis, increased dental decay, periodontal disease where you have red gums bleeding easily, and then ulceration of the oral tissue. The objective salivary flow rate, which is often not done for most patients, is a measurement that's done at least 5 minutes after fasting overnight or 2 hours after a meal. The normal salivary flow rate when stimulated is 1.5 to 2 milliliters per minute, unstimulated 0.3 to 0.4 milliliters. Hypostimulation will be a stimulated flow rate that is falling far short of those parameters. It can be tested a little bit more objectively with xylography, where you do radiology, where you inject dye and see if there is a good flow coming through, if there's no obstruction. There can be functional testing with scintigraphy and technetium-99. There is some value in sometimes doing cross-sectional imaging where CT or MRI can be performed of the salivary glands and see if there's been issues with atrophy or other issues of those glands that might be a harbinger or a sign that there is a problem with salivation. In management of this disease process, certainly prevention is probably one of the most important issues. So lifestyle choices does become very important in terms of all those issues we talked about: smoking, the alcohol, maintenance of weight, good diet. Adjusting medication dosages or considering changing medications may be of value, and this would be under the direction of your physicians or that are managing those medications. There are systemic agents that can be used to help improve saliva. And then more commonly, there are intraoral topical agents that can be used. In the management, you want to maintain excellent hydration, whether it's ice chips, liquids while eating, chewing slowly, breathing through the nose as much as possible. Many people will have no idea how much the nose humidifies the air that we take in and how important that is. Sucrose-free candies or lozenges have been used. Moisturizers on the lip and room vaporizers are all areas that can be used to improve the situation for patients. So this is a nice little cartoon to give a little pause here for a second. So here's a physician talking to his patient. I'm not sure what you have. I'd still like to treat it aggressively. So that sounds like a lot of physicians at times. And so if we're going to treat this aggressively, we're often talking about systemic agents. And there are some systemic agents, and these are not given without inconsequential toxicity or side effects. And so the FDA-approved sialagogues would be oral pilocarpine and cevimeline. The pilocarpine is a non-selective muscarinic agonist, parasympathetic agent. We use it a lot within our head and neck radiation patients to give them a trial, but we often have it for a very short-lived period of time. Most oral head and neck radiation patients don't get a lot of benefit from the pilocarpine and don't like the side effects of the pilocarpine. So the side effects are, once again, not inconsequential. They include vision changes, hypotension, nausea, vomiting, diarrhea, increased urination. It may be unsafe for certain patients to have these medications. And my own experience is that many of them have often not really felt a great benefit that would override the risks from that medication. Cevimeline is a selective muscarinic agonist, fewer side effects than pilocarpine, but once again, often not giving quite the benefit many patients would hope for, but something that could certainly be used to try to squeeze out whatever saliva you can from the salivary tissue. Avoiding oral complications, very important for these patients. So oral cavity rinsing after meals, brushing teeth and gums, flossing, fluorinated toothpaste, products sweetened with xylitol 3 to 5 times a day, professional dental examinations every 6 months, and use of professional recommended dry mouth products. And so as we move on to those, including intraoral topical agents, topical medications are often considered the first-line treatments recommended for xerostomia. And those agents can include candies, gums, chewing gums, and saliva substitutes. Sprays have been used for the treatment of xerostomia. I'm going to bring a little bit of attention to some of the evidence that's in the literature. And so topical products containing xylitol or betaine have been effective against medication-induced dry mouth. When we look at xylitol, it is a widespread oral agent used, non-fermentable carbohydrate, creates an osmotic gradient between the mucosa and the mouth, and it draws fluid from the cells to the surface of the tissue, replenishing the outer coating of the tissue and by extension the teeth, increasing the pH of the mouth, coating the teeth, and it's actually been shown to reduce the rate of caries by 10%. And so some value certainly has been seen from that within the literature and being objectively studied. So as we move on to our discussion portion of this procedure, in conclusion, there really is, although no standard treatment guidelines are available, many treatment options do exist for the management of xerostomia and hyposalivation. topical agents to alleviate and or prevent xerostomia are present. There are systemic therapy agents, and then certainly always newer devices and treatment alternatives, alternative medicines have been looked at as well and will continue to be explored. So thank you very much. I really do appreciate the opportunity to speak on this topic, and certainly interested in thoughts other people may have and other ways that we might be able to help our patients from the audience, or ideas that we could generate together here. So thank you again, Dr. Graham and Catapult and all our sponsors for the talking opportunity.
So Joe, I'm getting an echo, so I'm just trying to see. Okay, can you hear me?
Yes, very clear.
Oh, okay. So first off, I love the chart that, you have these 10 questions. I think we could all download the questions. But I guess my question then still goes back to, let's assume dentists are not going to be recommending pillow carpane and other things for their patients. It's really just over what we normally do. So I'm going to ask you, what have you found that really works and is successful? Because there's so many over-the-counter products like Biotine and others that don't work, that for me, I think it would be opportunistic for us to kind of discuss what can work, and how do you guide patients? So for example, I've seen time release xylitol tablets where you're putting them in your cheeks. Obviously we just started using, and we've had great success with Plaque HD. I'm just curious, how do you guide your patients through this now?
Right. So most of my patients, I've already stated, do not like systemic therapy. They don't like taking over-the-counter thing. They don't like taking Saligen or other medications because of those side effects. And so first of all, making sure they're doing all those basic maintenance issues. We really do emphasize that, seeing our dentist, the fluoride trays, all of that. Once all that is taken care of and they're not smoking, hopefully, or drinking too much alcohol, the topical agents have had the most benefit, without question. And I've tried many different over-the-counter agents as well. And certainly I put my disclosure up there in the beginning of the talk, but the product I have seen our patients using over and over again, and in my own practice, has been using the Plaque HD and Refresh, and they really have found great benefit from that. I'm very candid with them. I tell them I have had a relationship with it, and I said you can give it a try and see if it helps you, and if it does, wonderful. And they are over and over again really liking that, and I think it's helped them. And so I will continue to do what's in the best interest for my patients, which is helping them improve their quality of life and survivorship.
So, okay. So, Joe, when I look at medication induced, so I look at xerostomia two different ways as a dentist. If it's medication induced or with age, I think I've got a shot at it. And I can see using these wonderful over-the-counter products. I'm a big xylitol fan, and I've had great success over the last 4 months with this Plaque HD product. Agreed. Head and neck cancer patients, where their dry mouth seems even to the next level. Am I off here? Or, to me, when I get these referred from a Dr. Blair at the University of Chicago, they just seem even drier than medicationally induced xerostomia.
Yeah. They're absolutely completely dry, and radiation can be variable for patients depending on what kind of cancer they've been treated for. If it's a tonsil cancer versus a base of tongue cancer versus, as we talked about, some patients may have almost a whole mouth radiation. Anything that we can do to improve their quality of life is what my goal is. And I do tell them that it's not going to make their mouth perfectly the way it was prior to their treatment. I'm not looking for that necessarily for my patients. I'm looking to improve their quality of life, and that's what they're looking for as well. And so it is a new level compared to medication or aging, when you've been radiated. And unfortunately, as we know, for our patients who are being cured very well with radiation, we're dealing with multiple factors. Not only are we dealing with the radiation, but we're also dealing with the insult of the aging process on top of it, and the side effects of more medications that they're going to have to take because of their radiation or their, longer longer period of living. So all of those issues become additive onto their dry mouth problem.
And so if I'm a son of a parent or a dentist of a patient, are there specific, I mean, I know 400 medications, my God, Joe, it's such a long list. Are in your estimation, are there more specific medications that if we're really seeing high caries rate, tremendous xerostomia, I mean, you have a balance of, is it best that this patient stay on this medication versus the daily insults and the lack of a quality of life? Because severe xerostomia truly affects speech, swallowing, everything you said. Do we ever go to the point where we're telling physicians as dentists, maybe we need really to alter medications, or are we just not going there?
Yeah, we're certainly, we're unfortunately, in general, throughout the United States and most developed countries, we're not necessarily in the healthcare, we're in sick care, because many patients have become very sick requiring these medications, and some of them from choices. If we can control some of their underlying issues, whether it's blood pressure, diabetes, other issues that can alleviate some of the medications, that would be great. Having said that, there's still going to be the need always for these medications. That's the goal, to try to reduce the number of medications people would need to use. But when there's no alternative, then we need something to help manage the side effects of the medications. And that's, I think, where we have to go.
Yeah, I absolutely concur on that. And I think there's not one solution, because when I'm working with severe xerostomia patients, it's one thing trying to get a saliva substitute or something to make them more comfortable. But I mean, we have people, I call them remineralization trays, and we're using a variety of medicaments, some xylitol, some remineralizing creams, a variety just to slow down the potential of caries, because now you're dealing with the next problem and then you're dealing with perio. So a lot of times we're dealing with both perio and caries. And like, there's a system out there, Joe, and I'm going to go dental, it's called Perio Protect. And we make Perio Protect trays for every oral radiation head and neck cancer patient when they hit the degree of radiation that you were talking about, because it's going to be a huge problem. And I'm sure you would concur on that.
Oh, absolutely. And one of the things that's been exciting for me to get involved with this is just, as we've kind of spoken, at times we tend to all work a little bit in silos, whether I'm the head and neck cancer person, worry about curing the cancer, and then we have people working in, we all need to be working together for these patients for protection of their oral cavity and what comes from it. And it moves even beyond just the issues that we're talking about there. Once you have poor dental health, the caries, the periodontal disease, now you start to fall into issues of maybe even cardiac, systemic issues or disease that could come from all of this. And so trying to keep a mouth as healthy as possible is so important. It's not just about killing a cancer the way we used to think about years ago, but thinking about the whole person and, not quality of life issues, but also their general health and how important the oral cavity plays in general health and systemic health. It's not just local health, the mouth, it's systemic health.
So can I want to ask you, and then I'm going to answer ask a question that was just asked. Okay, I'm going to ask a guideline, and I'm not putting you on the spot, but if I'm putting you on the spot, you can hate me after the webinar. Okay. So tonsillar cancer, dentists are finding these things. It's not a good story. I just want to ask you this, two things, and I think I want to touch on this and then we'll get to solutions. If someone has X amount of radiation, which you touched on, do you recommend healthy molars in the mandible to be removed?
So this is an interesting question. Every single one of our patients at my own institution, the Cleveland Clinic, gets a dental evaluation prior to radiation. I do not make that recommendation myself, but I have wonderful dental colleagues who will look and see how their tissue looks. And if the molars are in good shape, they do not necessarily tend to remove them. Now, if the molars are not, if there's any concerns at all, they probably would not hesitate to have those removed prior to radiation because of the long-term effects of radiation and risk of osteoradionecrosis or
Right.
yeah. And I don't want to be back taking out a mandible, which I do on a regular basis with a fibula free flap.
Right. I've sadly seen this happen, and it's the catch-22 in dentistry. Is a mandible, if and it's routinely lower molars, not bicuspids, and it's just, I wouldn't want to lose my mandible, and everybody can hate me for hearing this, but it's just a cause of concern for me. Okay.
Absolutely.
Second question. We were talking about HPV oral cancer, and we were talking about radiation therapy, surgery therapies when it's an HPV cancer and it's not an HPV cancer. Could we just briefly talk about that to our audience? Because HPV, it's a huge thing. And I think the more our audience knows about HPV, the better.
Yeah, this is a huge, huge epidemic in the United States and throughout the world. It is something that is not discussed enough. It's starting to make the lay press more and more as some celebrities have, been affected by it and spoken on their treatments and what has happened. But it is a completely different disease than our typical cancer we used to see. And so in the past, the main risk factors have been primarily smoking and drinking. They remain risk factors, but over 85% of our new cancers at my own institution and most tertiary care centers are not from that cause. They're mostly from HPV or human papillomavirus. These are smaller primary tumors that will be in the base of the tongue or the tonsil. They'll generally present in Caucasian males predominantly, not females, usually in their 50s and 60s. Often presenting with a neck mass or lump. I wrote a guideline paper for our American Academy on the topic of how to handle a head and neck mass because we were trying to get away from the inappropriate use of antibiotics in adults over and over again when they had a metastatic regional lymph node from HPV cancer. Many people and physicians, other people have been fooled thinking, well, they don't have the classic risk factor of smoking and drinking. How could they have head and neck cancer? Once again, 85% of our new cancers are HPV cancers, tonsil, base of tongue, usually presenting with a neck mass. And so we're trying to prevent round and round of inappropriate antibiotics. In kids, you see a neck mass from an infection, but not in adults generally. And then we're also trying to avoid the inappropriate open neck lymph node biopsies that we can, try to find. And I'll have to say, I am so impressed with our dental community, our dentists, hygienists who pick up on these abnormalities in the mouth, whether they're abnormalities of the tongue, the tonsils, other areas, and are able to refer patients in at a much, much sooner point in time for treatment.
So I'm going to represent dentists because routinely most physicians have absolutely zero training on looking in the oral cavity, and you know exactly what I'm talking about.
Yeah.
When my physician in my annual exam says to me, say no idea what I'm looking for. So here's my question. Are there any new ways that dentists could be evaluating head and neck early signs of this dysplasia or precancerous lesions? Because obviously we want to try to find it before it's cancerous, especially these HPV lesions. Is there anything out there that we should be knowing about or that you can tell us about?
Sure. I think it's not a bad idea just to simply feel people's necks. They're in the dental chair there, take a little feel of the neck. to feel if there's a hard lump or, feel a lot of normal necks, and you'll certainly see or feel an abnormal lymph node, and that will be an alert. The other thing is many physicians may stick a single tongue blade in the mouth and say, go, ah, whereas a dentist, put both your hands in the mouth, use your fingers to push the cheek aside a bit, move the tongue around, look under the tongue, look at every mucosal surface, use 2 tongue blades in each hand as you look at all those surfaces, and you will pick up on small, subtle things that you would not appreciate with just a single tongue blade saying, ah, for a patient.
Right. I agree. Palpation and visual are two absolutely essential items. Okay. So we've touched on this, and now there are multiple questions coming in. I'm going to ask you, okay, Plaque HD. I understand you're a consultant for this course tonight. Catapult just evaluated this product, and openly, I'm so impressed that my geriatric patients in general who have dry mouth are asking me to repurchase it. I'm going to ask you what your thoughts are on this product and maybe why you think it's a little bit of a novel approach, and then I'll add my comments. So I'd love to hear your thoughts on the product.
Right. So I've tried it myself. Certainly I've used it. I do use it. I've had my own family members use it. And they've all been very, very impressed with it. There are other options out there over the counter. And so many of my patients have tried every option out there. And so when they're given this newer option to try, and they're telling me over and over again they've liked it, and we're stocking it in our wellness center, our pharmacies, and it's being bought and sold, to help them and their repeat customers, that is something that I think has been very, very valuable for them. It does contain the xylitol that we showed has the benefit. It does have all natural agents, no alcohol present. These are all things that make it a very appealing agent for patients to use.
Yeah, I kind of use it in combination with sometimes xylitol mints that people can also kind of suck on as an anti-caries effect. But what I noticed, and it was interesting listening to you, I think there's a difference, xerostomia and nighttime xerostomia, and you went through that. Most of my patients are saying that they're using it twice a night. So routinely, most of the guys are at least getting up, and often my older female patients, they're getting up once or twice a night, and that's when they're also rinsing, and it gets them through the night so they're not uncomfortable with this horrible dry mouth. And during the day, they definitely use it, but it's really the nighttime that I'm hearing, unless they have just profound daily type xerostomia. But oftentimes we can use other things during the day in addition to this. But I think at night, it's almost like a BID, but it's BIN for twice a night. I don't know, but are you seeing that your patients do prefer this while they're, getting up at night? I'm just curious.
Yeah, I see it both at night and during the day. So many of my patients who have radiation are carrying a water bottle around with them all the time during the day. And so I think it does hopefully cut down on how often they have to go to that water bottle just to get, a better feeling in their mouth. Some of the patients are asking me, exactly how to prescribe it, thinking the way a regular medication might be prescribed with some objective animal studies or other studies. Certainly that does not exist. So I tell them to use it as they find fit. If it's helping them to use it multiple times during the day or night, every individual is going to be a little bit different. If they have benefit from it, it's not harmful for them to use. So I tell them to use it as often as they think they're getting benefit from it.
Okay, I appreciate that. Questions? Joe, I really sincerely appreciate you bringing your thoroughness for Catapult. Really appreciate you being here tonight.
Thank you, Dr. Graham.